صباح النور. Um, we're supposed to cover areas of. I'm a uro-oncologist by specialty, robotic surgeon by training, and we're supposed to cover the 4 urological cancers as well as infertility and renal colic and renal stones. I don't like to give this as a lecture. I usually prefer to be as interactive as possible, show you as much images as possible. The text is there, you have it. My lectures are available, I think, to you for the past 10 years or so, so these aren't difficult for you to read. What we'd like to generate is some discussion and to try to identify the clinical context of the clinical aspects of what we're going to talk about. Now, since we have no projector and no videos and images to show you, I thought we'd maybe start talking about something that does not require imaging at this point, which is renal colic. So who of you has ever had renal colic or a stone before? Wow, you're all healthy people. Not one of you has had renal colic. Not one of you has seen a family member in renal colic. Guys, you guys are young. You have, okay. Can you tell me what happened to that person? Extreme bad pain. So she just said one of the pivotal things that moves the patients to a hospital in renal colic, it's the worst pain they've had in their life. It's equal to labor pain. That's how bad it is. So when you say, oh, doctor, عندي كلى, you don't have kila, okay? لما عندك مغص كلوي, you will be crying on the floor in pain. Take me to the emergency room now. I need morphine, okay? How did the pain start? Was it gradual or sudden? It was sudden, acute onset, severe flank pain. Did you have a chance to find out more about that pain? Can you let them hear in the back? They can't hear you.
I remember it was just sudden excruciating pain. It was, when this person was asleep, and then suddenly they woke up screaming because of the pain.
So woke them up from bed. That's another sign of severe pain. Okay, what else?
And when they go to urinate, they thought there was something, whatever. Nothing comes out. It's just like something stuck in between.
So typically, the pain is acute in onset. Could wake them up from sleep. I had renal colic once. I was in the middle of surgery. I dropped the knife. I couldn't continue my surgery. It was that bad. I had to have the anesthesia doctor give me an injection of painkiller just to go down to the emergency room. It's in the flank. It sometimes radiates to the front and to the lower abdomen, to the tip of the genitals. It may be associated with frequency, urgency. It may be associated with hematuria, commonly associated with nausea and vomiting. Okay, all these are typical signs of renal colic. And does a kidney stone usually cause colic? Unlikely. Kidney stones causes colic as the kidney stone is trying to come out of the kidney into the ureter. That's when the colic usually starts. But if the kidney stone is sitting in a collecting system far away from anything, it's unusual unless it's moving around and maybe causing some irritation or some bleeding. But usually as it's trying to come out. So most of the colic comes from urethral stones rather than kidney stones. So that's the typical presentation of someone with renal colic. What causes kidney stones? What are they made of? What are kidney stones made of? Sorry? So have you guys ever made syrup before? Syrup. Gatar, shira. How do you do it? Sugar and water. بس كده we mix them together ولا there's a chemical concoction behind it, okay? Or physical concoction behind it. Is when you increase the solute, okay? And you reach a crystallization point. Once that sugar starts to crystallize, okay, that's when you have syrup. The same thing happens in the human body. For us to get a stone, we have to have a high enough concentration of whether it's calcium oxalate, calcium, magnesium ammonium phosphate, uric acid, and low amount of water or urine, okay, because we're dehydrated, etc. These will crystallize, the crystal will form a nucleus, the nucleus will start to grow on top of it more crystals, and they will have a kidney stone. That's typically what stones are. What is the most common type of kidney stone? Calcium oxalate. Okay, that's the number one cause of kidney stone, and the number one cause is usually dehydration. But sometimes people have other causes that promote kidney stone formation, metabolic disorders that you can read about. Most common being uric acid stones, gout and uric acid, very common in our society, comprise about 10 to 15% of people with kidney stones. Sometimes they can be infective stones, people with long-term indwelling catheters, spinal cord injuries. These people usually have what kind of stones? Struvite, and these are made of what? Magnesium ammonium phosphate with calcium-based stones. Others are because of an inborn error of metabolism, such as cystine stones. You will commonly see these in children, in pediatric population. And these stones are very hard, and they are recurrent, and they may eventually cause renal failure in these young children. Luckily, they comprise less than 1% of stones. One other way we classify stones, whether they are radio-opaque or radiolucent. Radio-opaque meaning we can see them on a plain X-ray. And why is this important? Ease of diagnosis, and it can also help us with treatment and with follow-up of treatment. When you can easily see a stone on a plain X-ray versus having to do an ultrasound or a CAT scan to look at the stone and to follow up the stone. Also important in whether we decide to do straightforward shockwave therapy for a clear radio-opaque stone, while something more intense such as an interventional procedure. Okay, so typical patient comes to the emergency room, your relative, severe pain, you rush them to the ER. They're going to give him some painkillers to reduce his pain, okay? They're going to give him some hydration because he's been nauseated and vomiting because of how bad the pain is. It's more a vasovagal thing than an actual direct relationship of the stone. His pain is controlled. Now you need to diagnose him, right? What workup do you do? So imaging is paramount, and a urine analysis is paramount. So we do urine analysis just to look for, is there a UTI with the stone or without the stone? We think it's a stone, right? What ideal imaging would you do? So you can do an ultrasound, you can do a CT, you can plane a KUB, but today the gold standard is a CT non-contrast, okay? Thin cuts, C minus, no contrast, and it probably picks up more than 95% of the stones that may be causing the renal colic. Pardon.
We use CT. How are we using CT? If it's like
Depends where you are. Depends where you are. جالس انت في المركز الطبي في القويعيه, okay, and you don't have a CT scan, or CT scan is يعني overwhelming to use because they have a waiting list, I'll probably do an ultrasound or a KUB. جالس في الرياض في المركز الفيصل التخصصي, I'm going to do a CAT scan for the minute the patient puts his foot in the emergency room. It is more efficient, it is faster, and there is no يعني better way to diagnose a patient with a kidney stone other than a CAT scan. So today the gold standard is a CT scan, okay? So we do, and honestly, in a city like Riyadh or Jeddah or Khobar, there's a CT scan around every corner. So it's not difficult to do in any emergency room. So we typically do those imagings. What we have to determine when we image a patient with a stone are, it's not enough to diagnose the patient. Okay, so I've diagnosed you with a kidney stone. Okay, so what? I need to know more important things. Can someone,
what type of stone is it?
I don't care what type of stone, because type of stone at this moment, size, location, and the kidney. Is the kidney obstructed or not? Is it hydrophilic or not? So size, very important. Why is size important?
Because it depends, it will change the treatment and the risk.
Risk of what?
Maybe risk of obstruction.
Okay. Okay. Your relative, did he have a kidney stone? Did he have ureter stone? What happened to him or her? So it came out on its own. Now they told him they gave him something, but they gave him nothing really, okay? Because nothing works, okay? It comes down spontaneously. It's a spontaneous type of passage. What is the chances that ureteral stones will pass spontaneously? Depends on the size. That's why size is important to know, okay? So if a stone is 5 millimeters or less in size, what's the chance it's going to pass spontaneously? More than 90%, thank you. So if you have renal colic, you can withstand the pain. Instead of having a procedure, tell you go home, drink lots of liquids. We may be able to help you with an alpha blocker such as tamsulosin, okay? It can help passage. There have been other things, believe it or not. There's a study from Turkey that says sexual intercourse will improve the chance of passing a stone. So many gimmicks and studies out there, but the fact of the matter is the only thing that matters is fluids. Drink as much fluids as you can, and the stones in 90% of patients will pass. In 10%, they will not pass. They will cause recurrent renal colic, recurrent visits to the emergency room. They will cause hydronephrosis, maybe an infection. Okay, people with tight ureters. There are 10% of people who require an intervention. But what if the stone is between 6 to 8 millimeters in size? What's the chance of spontaneous passage? Maybe about 70%. And if it's above that, the chance of spontaneous passage is less than 10%. Yeah, sure. So, stone size is very important in figuring that out. Let me see if I can just send this over.
Which ones is it?
The oncology ones, they have some videos. All these.
Okay.
Just dump all these. Okay. With the videos. Is this on? Well, is the microphone on or just recording? Okay. So we talked about the size of the stones, chance of spontaneous passage. Second is location of the stone. Does it matter where the location of the stone is? Okay. Why? So it could be the kidney. We know where in the kidney, upper pole, lower pole. That makes a difference because an upper pole stone has a chance of passing. A lower pole stone really has to go under against gravity, has less chance of passing. Where it is in the collecting system, whether it's in the UPJ, which is a narrow part between the uretropelvic junction. The second narrowest part is as it's crossing the blood vessels, as you mentioned. And then the third narrowest part is at the uretrovesical junction, the UVJ. So it's important to know and to counsel the patient. The stone is almost out, or we're going to have a long time waiting. So I had a lady I operated on last week. She was actually a young doctor who just graduated, and she had a 5 millimeter stone that I advised for her to have watchful waiting. But the stone was up at the UPJ. She came back in severe pain 24 hours later, and I had to take her to surgery because the stone just wouldn't pass. And we had such a long time for that stone to pass. But more importantly, she developed an obstruction. And what happens when you have an obstruction to the kidney? It swells. We call that hydronephrosis. Is hydronephrosis bad? Yes and no. Okay? So if hydronephrosis is temporary, okay, if an obstructive hydronephrosis is temporary, and we reverse the hydronephrosis, will the kidney go back to its normal function? Yes. When? If I unobstruct her after 2 days, 2 weeks, 2 months? Okay? So we did an animal experiment on these. Animal experimentation was done where they tied the ureters of these animals and they sacrificed them at 1 week, 2 weeks, 3 weeks, 4 weeks, etc. We noticed that if you reverse the hydronephrosis, within 3 weeks, the kidney function will be restored eventually. If you go beyond 3 weeks, the damage becomes irreversible. So you always have to bear that in mind so you don't lose the kidney. Many a times the patient will say, I have a lower ureter stone, it's 8 millimeters, oh, my pain is gone, but he has hydronephrosis, and he disappears. He comes back a year later, 2 years later, بالصدفة, kidney is dead. Kidney is atrophic now. Why? Because he had no alarming factors such as pain to bring him to the hospital. He thinks he's okay, but that stone never passed. Why did the pain disappear? The stretch of the ureter eventually, okay, will stop peristaltic the ureter. No more pain. Patient feels fine, but they've lost the kidney. That's why if we have hydronephrosis, it is a very alarming thing, even if the patient says, I have no more pain. We have to do a follow-up imaging to make sure that that pain has in fact gone because the stone was passed and not because there's persistent stretch that's gone anymore. Okay, so we've imaged her relative. We found that he has a 1 centimeter stone stuck at the distal right ureter. His pain is now controlled. How would you go on treating this patient? Of course. But what will the urologist do, you think? Okay. The pain is controlled. We've done a urine analysis. There's no infection. We've done a CAT scan. We've diagnosed the location and the size of the stone. But we know now it's a 1 centimeter stone with hydronephrosis on the right side. What are you going to counsel this patient and tell him? You tell him you have a stone that's unlikely to pass spontaneously. Okay? It may still pass. It's unlikely to pass. What options do we have to treat that stone? Sorry? To the OR. To do what? هتقصبه. هذه ايش اسمها هذه اللي حتسويها؟ What surgery? You're no longer medical students talking as lay people. Now we're talking technical. الو OR اليورولوجيست جاي نبغى نحجز سيرجري للمريض. اول شيء تقول لك النيرس what surgery؟ ايش اللي يحضره؟ What am I going to prepare? It's called a ureteroscopy. Okay, so we're going to use ureteroscopic instruments. Okay, will the ureteroscopy be a diagnostic one or a therapeutic one? Therapeutic. So what else? So ureteroscope will get you to the stone. How are you going to treat the stone? قلنا حنسوي ureteroscope. ايش ultrasound guided؟ حددوا. Ablation doing. So we need energy to break the stone. Stones don't break without energy. Okay, you need to break them with something. You can break them with a sledgehammer, something called a pneumatic compression device. You can break them with EHL, electrohydrolithotripsy, or you can break them nowadays with laser, holmium laser in particular, thulium laser, many other kinds of laser. We need an energy source to go through the scope so we can put it on the stone and blast the stone into fragments. Okay, so you need ureteroscopy and laser lithotripsy. But what if I told you the same patient, in fact, had a 3 centimeter stone up in the kidney? Are there any other modalities of treatment other than ureteroscopy? Because the ureteroscopy is a very small machine, very small instrument. It will take forever to treat the stone and may cause damage in the ureter while you're breaking the stone for being there such a long time. So any other modalities? So you can do what's called a percutaneous nephrolithotripsy. You can put a scope in the kidney directly, a larger scope, okay, with a larger irrigation channel and a larger laser fiber or a larger energy source to break the stone, such as EHL or a pneumatic device to break the stones and fragment them out. So if I told you the patient had a 1.5 centimeter stone in the kidney, stone disease, top one. What if I told the patient had a 1.5 centimeter stone up in the kidney, pain controlled, no hydronephrosis? Hmm? I wouldn't leave it. It's not going to go away. So you can do something called ESWL, extracorporeal shockwave lithotripsy. Big machine, patient sits on, the ultrasound focuses or the KUB focuses, targets the stone, and we give shockwave therapy to break the stone. If the patient has hydronephrosis and we want to relieve the kidney, relieve the pain, relieve the hydronephrosis, what do? We can put a stent. It's called a urethral stent or a double J stent, okay, to temporarily unobstruct the stone that's causing unobstruct the ureter that's causing hydronephrosis by the stone. And then eventually either the stone passes by itself or we do ureteroscopy or we do shockwave lithotripsy. And then once it's solved, we pull the double J out. Okay. So this is what the crystals look like under a microscope. Someone who has stone disease, it's worthwhile looking into their urine analysis to figure out what kind of stones they have if you don't have the actual stone fragments to analyze. So you can see these crystals, and these crystals can be identified by the lab techs to give you a better idea of what you're dealing with. Risk factors in Saudi Arabia. Lots of people who move to the country don't realize how hot it is. They don't drink enough liquids, and that's how they usually get stones. More common in men, more common amongst younger Caucasians. Very common in someone who has a family history. In fact, 50% of people who've had a kidney stone have likelihood of forming stones as well. And very common in someone who's had a kidney stone themselves, of having another kidney stone within the next 5 years if they don't change their drinking habits. We've done this. We've talked about the diagnosis now. IVP. Does any of you know what an IVP is? Have you ever seen one? No. Well, you probably won't see one anymore. I've been in practice for the past 20, 25 years, and the last time I did an IVP was about good 20 years ago. It's a very good test, but it's cumbersome to do, and a CAT scan has way surpassed it, much faster, much more efficient, and much more accurate. And if we need a contrast study, instead of doing an IVP, I'll probably do a CT urogram. So same idea as an IVP, but only using a CT scan. So this is what a radio opaque stone, is it projecting well up there? Yeah, can you see the calcified radio opaque stone? Typical, about 1 centimeter stone. Why do I say it's 1 centimeter? Because it's around the size of the rib, diameter of the rib, right? So when you get this on an OSCE station, you say, well, this is a radio opaque stone, about 1 centimeter in size, over the shadow of the right kidney, around the level of the L2 vertebra. Another stone that's more longitudinal along the what looks like the UPJ area or the upper ureter area. What are these down here? More stones? Phleboliths. These are not within the ureter. These are out of the ureter. Very common finding in older people is to have phleboliths. This is a close-up, a magnified image of what's known as a jackknife stone, a kind of an infective stone or a struvite stone. Call them jackknives because they look like these. What's this? Sorry? Staghorn. What's a stag? الوعل. الوعل, exactly. And it looks like a stag's horn, okay? And why? Is because these stones are soft, so they form a cast within the collecting system that looks like the collecting system, and that's why they look that way. They're soft stones, they're easy to break, but as you see, they're huge, and they may take multiple sessions to clear. Typical non-contrast CAT scan, right kidney, you see a large 1.5, 2 centimeter stone in one of the posterior calyces of the right kidney. This is what an IVP looks like. So an IVP is a contrast study that looks into, we have a nephrogram phase and then we have the urogram phase, and they can see the contrast going down the ureter all the way to the bladder. What we look for in an IVP or in a CT urogram is the filling defect. So we expect the right kidney not to be hydronephrotic. You can compare the two kidneys, the left and the right. You can see the differences in the hydronephrosis. And the right kidney has a filling defect occupying most of the pelvis. And that is a typical hydronephrotic large renal stone, usually infective again. Yes. Mm. That's the same patient. Oh, no, these are clips from another surgery the patient had. Patient had the ones on the left side. You mean these over here? This is a stone. These are buttons. Patient was, and can you see they disappeared over here? Yeah, these are buttons. External. Okay. So we talked about stone size, location of narrowing, typical. We talked about this as well. Acute treatment, hydration, painkillers, blah, blah, blah. Workup, we've talked about. Management, we've talked about. Now, ESWL typically will only work for stone burden less than 2 centimeters in size. If it's above that, we prefer surgery, such as percutaneous nephrolithotripsy. It's very unusual nowadays to do open stone surgery or laparoscopic stone surgery. Extremely unusual. This is what an ESWL machine looks like. Patient sits on the machine. We do a plain X-ray with a C-arm. If it's radio opaque, if it's not, we'd have an ultrasound. We target the stone, and then we blast it. This is what the percutaneous nephrolithotripsy looks like. We come in from the back of the patient into the kidney, where the scope goes directly into the collecting system and breaks the stone. Ureteroscopy, we have two kinds of ureteroscopy. We have a semi-rigid ureteroscopy for distal stones. We have a flexible fiber optic scope that goes up into the collecting system and examines the kidney. And that scope usually has maneuverability, where you can go into various parts of the collecting system to pass your stones, your stone lasers, or your baskets. This is what it looks like inside. So the pink part are the walls of the ureter. That blue thing on top is a guide wire that helps us always keep our bearing. We know where to follow up and down. And that yellow part over there is a couple of stone fragments within the lumen of the ureter. These are two stones. That's a stone again up front. And that's a laser fiber passed through my scope, placed on the stone itself. And the laser fiber will be activated with a foot pedal, and it'll fragment the stone into smaller fragments. We talked about stone composition, metabolic disorders that cause stone composition. Honestly, I don't really care if you know the metabolic causes of stones. What I need you to know is the most important way to prevent stone formation that compromises about 80% of stone prevention is what? One thing, which is it? Hydration. Okay? Always tell the patients with stones, please walk around with a water bottle. There's an app, there's a smart water bottle. Get it. It'll save you a lot of the agony. Now, if you have an underlying cause, such as hyperparathyroidism, such as uric acid, great, that's fine. These compromise 10% of patients. What are the most important organisms that cause infective stones? Proteus and uroplasma. Okay, we're talking about staghorn stones, another image there of a staghorn stone. Cystine stones, it's an autosomal recessive disorder and common in the pediatric population. We talked about prevention, at least 2 liters of urine output per day. To achieve that, you have to drink more liquids than what you're putting out. We talked about the relapse rate. Now, if you're really worried about the metabolic workup of these stones because the patient has a recurrent stone firmer, you can send them to the nephrologist who can do 24-hour urine collection and look at urine volume, pH, and various solute concentrations to better advise the patient of what works better for him versus the general rule of just drink more fluids. Other things you can do is you can use citrate-based binders. These help in reducing stone formations. A low sodium diet, low protein diet also help. So no, no, with cystine stones you can't prevent them from. You can try, but they'll still. It's very aggressive. You take cystine, you take citrates, you take water. It's very hard to stop cystine stones from forming. These are the take-home messages. One of these will be on your multiple choice, I'm sure. Okay, remember them. Okay, any questions? Either very clear or too much. Okay, طيب.